Good morning. I'm glad to see you, or actually whatever time of day it is, wherever you're watching this. If you're watching from someplace else here in Orange County or California, we are just so glad that you are here. Welcome to the How to Navigate a Mental Health Crisis. And we have a lot to cover today. So much material. We can't possibly say everything there is to say about how to navigate a mental health crisis, but we're going to give it a good try. And just at the very beginning, the total housekeeping details for those of you here in Tent 3. Maybe it's your first time. The bathrooms are to the left of me, and you are welcome to get up at any time and use those or go outside if you need to. I want to make sure that you check out the exhibitors that are here in the tent. We have Dee Dee Hirsch. If you're not familiar with Dee Dee Hirsch, they do great suicide prevention work. We have our local NAMI chapter is here. We have Chalk Children's Hospital, Orange County Behavioral Health with information that's really vital to a lot of us, and then some information on Saddleback at some tables. There's also, as always, our prayer team that's here and available to pray with you. We have counselors here, some of our church counselors who, if you just need somebody to talk to or you need a moment to have some time for somebody just to listen to you, please feel free to do that. Our schedule for today is pretty simple. I'm going to just do some opening remarks, and then we have two main speakers whom I'll introduce, Steve Pittman and Pastor David Mondani. So we'll have a little bit of time with them, and then at around 10:30 we'll take a break. And you'll have a 15-minute time to, get something else to eat or take a walk or just be quiet for a little bit. And Pastor David will come back and tell us a little bit more. We'll have time for a question and answer. And then hopefully let you out of here at, 4 or 5 today or something. Just kidding. And then just some closing remarks and time together. I'm so glad you're here. Nobody really ever wants to be in a mental health crisis. Nobody ever wants to think of their loved one. And the reason that we're doing this, honestly, we have dreamed of this day for about a year. Mostly because the question that our team gets more almost than any other question is, how can my family get through this mental health crisis? Or how can I get through a mental health crisis? I don't know what to do. We don't know what to anticipate. It's scary. And so we started thinking about what could we do that would help people the most in daily life. But I also want you to know that we're not coming from the place of just objective, this is what we hear in ministry, this question of how do you get through a mental health crisis. This is coming from such personal places for all of us. Those of us who are presenting today or part of this, we know this place of chaos and fear and anxiety and uncertainty. We know it from our own families. We know it from multiple mental health crises that our families have gone through. We know it from the perspective of a brother and a granddaughter and a son and personal experience. And we know the times that the system has worked and gave us a little bit of help. And we know the terrible times, honestly, that the system feels like it failed, that it wasn't there, that we didn't have what we needed. And we know the drama. From personal experience, we know the drama and the trauma that can come from hospitalization. We know the scars and the wounds that have been left by some of those experiences. We remember sadly, the jaded faces sometimes of both law enforcement and hospital personnel, ambulance drivers, psychiatrists and therapists who didn't seem to care about our loved ones. And we remember with great sadness the helplessness that many times that we have felt as we did everything we know to do and begged for somebody, please, to help our loved one. We know what those feelings are like. We also know it from the inside. Pastor David knows this from personal experience, the terror and shame of being the person in the locked unit, the one person who has hated the forced schedules and the watching and the fear of not getting better and the question of who can help me? And we've heard hundreds of stories, not only our own stories, our own family stories, but we've heard the stories of hundreds of people here in this church. They come online, they send letters, they send texts. We encounter people in the grocery store and in the gas station, where sometimes people will just say, "Can I talk to you for a minute about my story or my loved one's story?" And many of you would say, in the mental health crises that our family has gone through, the different ones, we were unprepared. We didn't know what to do. We didn't know what to expect. I've held people as they wept bitter tears because they had an expectation of what would happen in a crisis if they sought help. And when it didn't happen the way that they thought it was going to, many have felt let down, have felt betrayed, have felt that a system doesn't care, that there is a system of people who are just doing a job and filling the hours on their time card, but are not filled with compassion. The stories are painful and heartbreaking, and many of you, some of you are here because you've already been in those places. Some of you are here because you're afraid that's where you're going to end up, or someone in your family is going to end up, and it's terrifying. And so almost a year ago, our team sat down in front of a huge whiteboard and said, what can we say? What do we need to say that will help people face some of those hard moments? What will give them hope? What will give them information so that as it maybe someday actually face some of those crises, they'll know what to do, they'll know what to expect. And on that day, and we spent a day just whiteboarding, dreaming, well, we have to talk about this. Well, we have to talk about this. Well, you can't forget this. We have to include this part. We have to make sure we say this. Or we have to prepare people for that. That very day, as I got online and just typed in those words, how to navigate a mental health crisis, I found that NAMI the National Alliance on Mental Illness, had just released a very large booklet on that topic. And it felt like this was perfect timing, that what NAMI had learned from their thousands and thousands of family members and what we had learned as family members and professionals here at Saddleback Church. I'm not a mental health professional. I didn't mean to put myself in that category. We thought we can combine that in such a way that will help people to know what will happen maybe with their loved ones. So what we want to share with you today is information that is current here in Orange County in California. And if you're watching online, you need to know that some things are different. Legal codes are different in different states. And you need to make sure that you stay current with what's happening where you live. But this is what we're going to be talking about here. And I have to tell you, there's some language in the law that can make you pretty uncomfortable. They use terms like gravely disabled. And if there was ever a shaming set of words, it would be that, gravely disabled. It's just a legal term. But there are things like that in the code and in the system that can put you off and make you think that you're being treated like less than human. And so we want to just cover some of the things with you. We know this is really hard stuff. We know these are hard waters to navigate, and no one ever wants to be in this place. And so what we're talking about today, I just want you to know that while we're going to be talking about hospitalization and aftercare, because that's typically where people in severe mental health crisis end up at some point in their life, is possibly at least in the emergency department, if not hospitalization. But I just want you to know that I dream of a day in which hospitalization is not our only option for people who are struggling with severe mental health crises. That's a medical model, and there's nothing wrong with that as far as it goes, but I just want you to know that I'm aware that there are maybe some different ways, some more compassionate ways, some more tender ways to help people. I can remember so many times that Matthew, in his severe depression and suicidal ideation, would say, "Why am I being locked up for being depressed?" And so I just want you to dream with me. Those of you that are here, I don't know all the answers. I don't know what that will look like, but I know there aren't many places here anywhere that exist where if you're really extremely depressed, you're extremely anxious, you're really going through a hard time, that people automatically think that you need to be either taken to the hospital or actually admitted to the hospital. There are times. But I'm just wondering if there isn't another way that we can, if there are homes, if there are centers where people who are struggling with a severe crisis can, in a more home-like atmosphere, be given just somebody to listen to, somebody to sit with them, somebody to walk with them through those hard times. You dream with me about this. I don't know what all that's going to look like, but I just want you to know that we know that hospitalization and emergency room is not the only answer for people who are struggling. So I want to introduce the speakers to you. Steve Pittman is going to follow me, and Steve graduated from college in 1969, and he became a lawyer in 1984. Started his career in education as a teacher and then in administration. After he graduated from law school, he started an insurance company that he still owns and operates. And he came into the mental health community through the experience of his brother, who lived most of his life with schizoaffective disorder, and he had a granddaughter who lived with bipolar disorder. Both his brother and his precious, beautiful granddaughter are deceased. He now serves as the director of NAMI Orange County. He has served at the national level and back here in Orange County. And he serves as a teacher for some of the NAMI classes that some of you may have taken. The family-to-family class is taught that at Saddleback. And then Pastor David Mondani, many of you know David. He's a licensed social worker and the pastor of mental health at Saddleback. And he's currently in seminary getting his second or third or fourth or 25th, I don't know, master's. The man's brilliant. Diagnosed with schizophrenia at 18, David offers a unique perspective as a person with lived experience, and he is fully committed to sharing the hope that he's found in Jesus Christ. As a social worker, David worked in interdisciplinary treatment and compassionate care in both the emergency room and in inpatient psychiatric hospitals, doing psychiatric evaluations, coordinated transfers into inpatient units, also worked directly with insurance companies and behavioral health staff as a utilization review coordinator, advocating for continued stay focused on patient-centered care, and helped people get into aftercare programs after being hospitalized. So David brings a rich personal and theological and professional perspective to this. So I'd like you first to welcome Steve Pittman. Okay, I forgot something really important. Really important. Steve, come on out. But what I forgot to tell you is in your notebook, it can be a teeny bit confusing. So if you will just open your notebook with me for a moment. And in the very front of your notebook, you'll see stapled together some pages. Those are Pastor David's notes. He has a lot of slides that he's going to be covering, and you don't need to worry about trying to take down all the information on the slides because they're right here, already printed for you in these notes that were tucked inside your notebook. And then the notebook itself, the very first, how many pages there? About 50 pages is that NAMI document called How to Navigate a Mental Health Crisis. So we printed it for you, again, so that you have it as a resource. So many things that we won't be able to cover are actually in this document. But if you look at that, at the bottom of each of those pages, there's a blue ribbon. And that blue ribbon corresponds to the table of contents at the front of our notebook. So we have NAMI's document within our larger document, and that's why there's that blue ribbon at the bottom that will refer back to. If you get lost, you go, wait, where are they? You can go back to the table of contents in the front, look at the bottom of each of your pages at that blue ribbon, and that will help you orient yourself as to where you are. So there is this very large document from NAMI. There's something that we call a portable medical record, which David will explain. There's also some information about if you, what it would look like to be placed on an involuntary hold here in Orange County, both at the adult level and at the pediatric level. There's also some documents on if you've been hospitalized. There's a pamphlet for family members. How do you help your loved one if they've just experienced maybe a suicidal episode and they've been hospitalized? So there's a document there for you as family members. And then there's also another document if you were the person who experienced a crisis, and there's a document for you on how you can then go from there and begin to heal and seek further help. There's some HIPAA information in here, the Suicide Lifeline document, and then there's also a flyer that is if you needed to call the crisis assessment team. So because there is so much to cover and we can't cover it all, we wanted to put it here in one place for you to grab onto. Okay, with that, now please welcome Steve Pittman.
Thank you. First, let me say that I would be remiss if I didn't first thank Rick and Kay Warren and Saddleback Church for the leadership One of the essential ingredients of any treatment program is hope. Families need it, those living with mental illness need it, and there's no better place to get it than through the faith community. So I extremely appreciate all that they. Can you still hear me? Okay. Secondly, I want to make it clear, I have no clinical training. I'm not a marriage and family counselor. I'm not a licensed clinical social worker. I don't have any of those degrees. I learned about these things just like most of you are learning about them. So let me first share a little bit with you about my granddaughter, Melissa. Melissa and her two siblings moved in with my wife and me when she was 7.5. Her mother, my daughter, was pregnant at that time with a fourth child. But Melissa had struggled a bit in the first grade. She had a difficult time making friends. We thought that the reason she had difficulty making friends is that she was so bright. And first grade kids didn't want to talk about things that Melissa wanted to talk about. So in the move here into Orange County, we thought, well, we'll just skip her through the second grade because academically she's not going to have any difficulty with third grade work. But then she'll be working with a different age group, and the friendship thing will cease to be a problem. And so we did that. And I can remember taking she and her sister to school every day. This is after my wife goes through the prep for school time, both in matching dresses, both with their hair pulled back as far as it could, and their eyes are this big. And I would get them to school, and Brittany, her sister, would trip going to greet her new best friend every day. And Melissa would stand between the door of the car and the car, straightening herself, making sure all the hems are just right, the stockings are right, everything is perfect. And when I would pick them up at the end of the day, Brittany would show up looking like she'd been playing soccer all day long. Runs in her stockings, the hems are gone, she's a mess. And I can remember Melissa looking at me once and saying, "Papa, I don't understand. Brittany doesn't even care about friends. And she has all the friends she wants. And I care deeply, and I can't make them." Then I remember when she went to another school, at recess time, she would always go to the principal's office. And we thought it was nice that she had a relationship with a member of the school staff. And this lovely lady always had candy on her desk for Melissa. We didn't understand, didn't realize the reason that she was in the principal's office was so that she didn't have to be on the playground with all of the other kids. So just having those problems doesn't mean you're going to develop mental illness. And it doesn't mean that the 8-year-old little boy who can't sit still in his chair at school and refuses to raise his hand as often as the teacher would like and has difficulty with his penmanship, it doesn't mean that they're going to develop mental illness, but it means that as parents, you need to be paying attention. You know, you all remember the old saying, well, just ignore it, it will go away. Well, I'm here to tell you, ignorance is not going to help. You need to be paying attention. And one of the really valuable things you get out of the school experience as parents is you have a teacher that's been standing in front of 10-year-olds for 10 years, and she knows what normal 10-year-old behavior is, and when she or he starts to tell you that your child is out there on the ends of the spectrum, again, it doesn't mean they're going to be developing mental illness, but it means you need to be paying attention. When my grandson, who's now 13, started to have difficulty at about 9, raising hands, calling out, difficulty sometimes socializing with other kids, the teacher immediately said, you know, he needs to be on something. He's got ADHD and, you know, all of those kind of things. We didn't do it, but we did talk to a psychiatrist, and we did have him talk to a psychiatrist, and we started, you know, let's pay attention here, folks. There may be something going on. It could be something he's passing through. After about a year and a half, he started taking a very low dose of a medication. He reported to his mother and father that he really felt calmer with it. It was easier for him to get his work done and do other things. So again, just because you see some of these behaviors doesn't mean you're developing mental illness, but it means that as parents, you need to pay attention. One of the things that I have here on my list is trouble with sleep. That's an issue. Almost every mental illness is linked to a sleep disorder. Irregularity of sleep patterns. Changes in behavior, any kind of change. At one time he was this way, now he's this way. He's quite different. Those are things you need to pay attention to. Feedback from the teacher you need to pay attention to. Temper or withdrawal. A young kid in particular, who starts to hit on walls or hit on things or break things. Those are not positive signs. Preoccupation with the internet. You know, they've kind of withdrawn. They're on their Game Boy all the time. We had rules in my car, no Game Boys in the car. No, this is a time for talking. Now, there are other times for talking too, but you don't get in the car and bury your face in a computer. You know, we're trying to interact, and you just simply can't do it on a computer. At the very first sign, you start to assemble information, long before the first crisis hits. You don't wait to look up the number to call the fire department when your house is on fire once it catches fire. You know, I can remember when I was growing up, above every phone in the house was a number to call the fire, 911. There was only one number. There weren't 100 numbers. There was one number. That's all you had to do. When these crises hit, they affect you as much as they're affecting your family member. And if you've assembled a book with 1,000 resources, you're not going to be able to find the one you want. So you want one number, maybe two numbers. This is what you call. And my advice to you is call the numbers now when there's not a crisis. Check it out. See how it works. They may say, no, we've got a better number for you. Get that number. Discard the first one. But call it out. Try it out. See what works. The next thing that I want to tell you, and this is going to sound odd, I know, but I insist, and I think Kay and Rick Warren are excellent examples of this, and I suspect many of you are too. This is a journey, folks, from pain to purpose. You have to ask yourself why this has happened. And you can conclude that this horrific thing that has happened to your family is not something that you're ever going to speak about because of embarrassment, because of shame, because of stigma. Or you can decide we're going to take this gift and decide what we can do to help other people. And it's in that purposeful journey that you will regain your strength. My brother lived with schizoaffective disorder for 50 years, was never able to talk about it. We never talked about it in our family. Siblings that I had that were spread all over the United States, when they were on the phone with me, would never say, so how's John? John and I lived 20 miles apart, so we saw each other on a regular basis. Never say that. With Melissa, the family of my creation, because Melissa and her siblings ended up living with us for basically the balance of her life, We talked about it whenever anyone wanted to talk about it. It was not a taboo subject. We normalized the conversation. We took away the stigma. It's perfectly fine to talk about it. That's the environment that we wanted to create for stigma, or to combat stigma. And you know, when you decide to have children, you pray for 10 fingers and 10 toes. That's about it. You certainly don't ever pray for mental illness. But the question is, now you got it. What do you do? And as I've often said, you know, the most addictive drug in the world is not meth, it's not heroin, it's not fentanyl, it's service. And when you can figure out a way to be to service to other people, you will heal. And frankly, when your family member living with mental illness figures out a way to serve others, they will heal. Melissa died when she was 28 and a half. It was not a suicide. But I'll never forget. Never forget. I'll never forget at her celebration of life, this little girl came up to me and she said, you know, Papa, Melissa saved my life. And I didn't laugh, but I must have smiled or something that was not really the appropriate response. And this little girl looked at me with tears running down her cheeks, and she said, no, Papa. She said, if it weren't for Melissa, I wouldn't be here. And what better thing can you do with your life than serve others? And the people in this room happen to have been given something not everyone has. So now what do you do with it? And I guess that's the question that confronts each of us. Next, at Saddleback Church here, twice a month, we have a support group led by a lady named Nan. Meets on the second and fourth Monday of every month. Sometimes there's 15 people, sometimes there's 30. Some people attend every 2 weeks. Some people come when they need to. You all are welcome. But one of the things that Nan said is the most important part of her dealing with the crisis was getting off the roller coaster. For the first 4 or 5 years maybe, every time, you know, she's up and she's down right along with her son. It's hard to be objective, and it's hard to really give the support that they need if you're as emotionally overwrought as they are. So the big first step for her in terms of dealing with crisis was getting off the roller coaster. He's still on the roller coaster, but when he's going up and he's going down, she's in a much better position to help him than she once was. So I would encourage you all to consider that. Another thing, what might a crisis look like? Kay intimated that crisis can come in a lot of different forms. Crisis on one end of the spectrum can be the person who never leaves their bedroom, eats at night, sleeps during the day, you know, just completely isolated when withdrawn. And on the other hand, a crisis may be a combative, agitated mood where people feel at threat of their behavior. So that crisis can take a lot of different looks. On one end of the spectrum, if somebody seeks help, there's such a thing as a voluntary hospitalization if it's needed. It doesn't have to be involuntary. And lots of times people on that one end of the spectrum, Melissa, my granddaughter, went into the hospital a number of times voluntarily. And the nice thing about that is they can still feel like they're completely in control. My brother, on the other hand, more often than not, it was involuntary. And that means a 5150 here in the state of California and in many other states as well. It also means danger to yourself or others. Here's the frustration for most families. You can have a child, a family member, who's floridly psychotic, and you know this is not them that's speaking, this is the disease that's speaking, and you want nothing more than to get them help, and you call the CAT team, the crisis assessment team, and they come out. There's no law against being floridly psychotic. You can be having conversations with 10 people at a time. They are not going to hospitalize them. The standard, again, is danger to yourself or others, which comes at huge frustration to family members because what you want is you want to get them help. I can remember turning to CAT team members and psychiatrists and other professionals when they're turning my brother away and asking them, how much damage does he have to do to himself before someone will help him? And oftentimes, it was kind of, we're limited in terms of what we can do. So those are areas where we can all come together and advocate for different standards, but that's the way the law is now. I've also talked about, in terms of the spectrum of crisis, poor attendance at school is a sign. Again, these are not to be ignored. This is not the time for ignorance. Drug or alcohol use, new friends, suddenly a whole new circle of friends, people you don't know. Not always a good sign. I mentioned change of sleep pattern, agitation, hearing voices, threatening, clenching of fists. All of those things you need to be paying attention to. I've already commented about the hearing the voices. Understand, too, most of these folks are very, very bright. If in our family-to-family classes, as people are introducing themselves and their family member, if I had to put together what they're going to say, the first thing out of their mouth is, you have to understand, my family member is really bright. That doesn't always work to their advantage in terms of seeking treatment with mental health. My brother was very, very bright, and he rented a room with a woman for a period of time. And when he would become really psychotic, she would lock him out of the house because she was frightened. And he would try to crawl through the doggy door, and this generally would go on for several days, and finally she would end up calling the police. And the police would come, and generally they come with the CAT team, so the CAT team is kind of the first perimeter, and then the police are there just to address safety issues. They're in a kind of a broader parameter. And my brother would say to the police, I own this condominium, and I rent a room to this woman, and she's locked me out. Well, what do the police know? So here is this woman, at 2:30 in the morning, going to try to find legal documents to prove that it's her house. And then she finds herself at the center of these two perimeters of circles, and she realizes that the CAT team and the police department are kind of like this. And they're trying to figure out who really has the problem at this point. That's why you got to get off the roller coaster. The other thing that you have to do is you have to take care of yourselves. Have to. Dads seem to have an easier time doing this. Moms are all in. Moms are in forever. When we teach our family-to-family classes, I always count the number of dads in the room. If it's more than 25% of the people in the room, it's unusual because they've checked out. Now, sometimes maybe that's the right decision. The moms don't ever check out. They're in it to the bitter end. The only way you will be able to survive on this journey is to take care of yourself. You got to figure out how you keep your tank full. The father of modern stress, his name was Hans Selye, taught at McGill University, did research on stress. The way he talked about stress is he said it was like the gas tank in your car. If the tank is full, you can endure stress fairly well. If the tank is empty, if you're running on empty, you're not in any position to go anywhere to do anything. So for each of you moms and dads too, you need to figure out how you refill your tank. And then the hardest part is doing it. Whether it's painting or walking, doesn't matter what it is, but you have to go to bed every night with your tank full of gas because you don't know when the next crisis is going to hit, but you do know that there's going to be another one, typically. I pray that there won't. And now I'd like to read you something that comes from one of the NAMI classes. I'm often asked to describe the experience of raising a child with a disability, in this case mental health, to try to figure out how to help people who have not shared that unique perspective to understand it, to imagine how it would feel. And it's like this. When you're going to have a baby, it's like planning a fabulous vacation trip to Italy. You buy a bunch of guidebooks and you make wonderful plans. The Colosseum, Michelangelo, David, the gondolas in Venice. You may learn some handy phrases in Italian. It's all very exciting. After months of eager anticipation, the day finally arrives. You pack your bags and off you go. Several hours later, the plane lands. The stewardess comes in and says, "Welcome to Holland." "Holland, you say? What do you mean, Holland? I signed up to go to Italy. I'm supposed to be in Italy. All my life, I've dreamed of going to Italy." But there's been a change in the flight plan. They landed in Holland, and that's where you must stay. The important thing is that I haven't taken you to a horrible, disgusting, filthy place full of pestilence, famine, and disease. It's just a different place. So you go out and you buy new guidebooks, and you learn a whole new language, and you'll meet a whole new group of people you would never have met in Italy. It's just a different place. It's slower paced than Italy, less flashy than Italy. But after you've been there for a while and you catch your breath, you look around and you begin to notice that Holland has windmills. Holland has tulips. Holland even has Rembrandts. But everyone you know is busy coming and going from Italy, and they're all bragging about what a wonderful time they had while they were there. And for the rest of your life, you will say, "Yes, that's where I was supposed to go. That's what I had planned." And in the pain that will never, ever, ever go away, because the loss of that dream is a very significant loss. But if you spend your life mourning the fact that you didn't get to Italy, you may never feel free to enjoy the very special and very lovely things about Holland. Thank you.
Good morning, everybody. You will find on your seats a 3x5 card right here. And if you have any questions for Steve or myself or Kay, we will be having a Q&A time. We'll be collecting this at break time after my presentation. Okay, so please take note if you have any questions. This training was meant to be for people who have and are living with mental illness, like myself. I live with schizophrenia. I have been in the system, in and out. And it's also created for families, families who have loved ones or friends who have loved ones who are also living with mental illness. Our hope today is to give you some practical tools or maybe bits of information that might be helpful in navigating a mental health crisis. If you give me just a moment here, my laptop is not working here. Okay, there it goes. We can go ahead and get started. So far, we've talked about a crisis and maybe some event for the person that you love or you yourself have gone through that has been a trigger to bring you into a place where you feel like you lack control or you feel like you're not sure what your options are. And so oftentimes a crisis and a mental health crisis will culminate in your journey of moving into an emergency room. And in an emergency room, I'm just going to talk a little bit about some of the expectations, if you haven't been in there before in a crisis, to anticipate as you prepare going in to care for your loved one and to fight for your loved one. Granted, I'm going to be sharing a little bit more of a technical or medical model, as Kay spoke about earlier. So please forgive me if I use language of the industry. It's nowhere meant to shame or to put down you or your loved one. We know here at Saddleback Church that God has created you in His image, and that He loves you very deeply, and that your illness is not your identity. So we'll go with that going forward. You may find coming into the emergency department that you or your loved one may not be admitted after long waits. You'll be sitting there with your loved one, and your goal, you've been told maybe to go into the emergency department to care and get an evaluation to determine, as Steve talked about, if someone meets criteria, basically being a danger to themselves or others. And so you may not be admitted. You may have long stays in the emergency department. It could be 5, 10, 12. I've heard stories of 15 hours. And though we have a broken system, as Kay talked about, your journey oftentimes brings you into a place where you are in an emergency department. Know that your insurance eligibility will determine where your loved one or yourself will be admitted. It may not be particularly the hospital that you're in. I will say this, it depends on what region you are, but for here in Orange County, we have a number of psych hospitals I'll talk about in a second. And oftentimes, based on bed availability, whether or not they have a bed available for your loved one if you're admitted, will determine where you go. And so a lot of coordination is going on the hospital staff side to make sure that your loved one gets a bed, and if they don't, they might have to transfer. They might have to transfer, and just be aware that it's commonplace for a hospital, if you are held involuntarily, that you will be transferred by ambulance, and oftentimes you will have restraints, leather straps that will hold your loved one. So be prepared for that as well. Sometimes you might be sitting in the emergency department, and as difficult and as very difficult it is for the person with lived experience, there could be security guards that will be there, they'll be assigned to you and sitting there, and it might feel intimidating, it might feel daunting. I know that everyone's experience is different coming into the emergency department. Some people actually want to come in, as Steve talked about, voluntarily, and I'll touch on that in a minute. Others don't want to be there at all during a mental health crisis. And again, there might be restraints while you're in the emergency department, or restraints as well if you're being transported. And remember, it could be very crowded, very crowded. So you're going to see things, you're going to smell things, you're going to experience things, the pain of other people while you're in the midst of your own trial. And so one way I'd like to encourage you is, if in preparation before a crisis, is to put together a crisis kit, basically containing information and physical items. That can be when you go into the emergency room, maybe you want to bring a day's worth of clothes, some hygiene items if you want to brush your teeth, or for, hygiene items for your loved one. You might be there for a sustained time. Also, I'd encourage you before a crisis is to put together a portable health record. If you look at page 39 of your packet, you're going to find a sample portable health record. Feel free to use that. And what it is, it's information regarding you or your loved one's history that you want to keep updated. And we'll talk a little bit how this can be a tremendous tool in aiding and collaborating with professional staff in your advocacy for the care of your loved one or friend that you're working or walking with. When you come to the emergency department, a mental health evaluation will be done. Again, if your loved one is talking about suicide, and you come into the emergency department, an evaluation will be done by a professional. And basically, they want to determine if your loved one meets criteria for an involuntary hold. So what is this criteria that a professional looks at? Let me talk a little bit more in detail of the criteria. Criteria for involuntary hold, also known as a 72-hour hold or 5150 hold in the state of California, includes evaluating if there is a probable cause, and this is language from the legal code, to believe that a person is a danger to themselves, so they're suicidal, or a danger to others, homicidal, or gravely disabled. Gravely disabled just basically means due to the symptoms of mental illness, you're unable to care for your food, clothing, or shelter. For example, you might be paranoid and afraid or delusional that the food is poisonous, so your loved one is not eating. Or you may be discharged from the emergency room and into the snow, and you have no plan for shelter or a way of understanding how to really take care of yourself. So those are just a few examples. We know that your loved one coming into the emergency room for the evaluation may present differently than the way they've been talking with you or as a friend. They may be sharing because they trust you or love you that I want to take my life and this is what's going on in my mind. But when they come into the emergency room, sometimes it could shift a little bit, and they might share a different story or present, if you would, differently to the person that's doing the evaluation. So be prepared for that. In addition, the reason we need a portable health record available is sometimes the individual coming to the emergency room for an evaluation may be a poor historian, meaning that maybe the symptoms are just so deep and wide or severe that the individual's unable to communicate or share things because, rightly so, they're just having a very difficult time with with the symptoms of mental illness. And so it's important that you have this portable health record available so you can communicate with hospital staff. So if an evaluation is done by a peace officer or a crisis assessment team professional out in the field, an involuntary hold application may be written in the field so the patient or your loved one actually will be seen by a psychiatrist or mental health professional and brought to confirm the hold. And so oftentimes when you're going into an emergency room, that isn't the only way that a hold is written, or what they call 5150 is written, a 72-hour hold. It can be also done by a peace officer who is trained here in Orange County. It can also be done by a central crisis assessment team as well, where the crisis assessment team comes out to your house and or your apartment or wherever you live, and they'll do an evaluation to determine if they meet criteria and write the hold. Oftentimes what we'll find is that people will be transferred from another hospital into the unit that you're in. But basically, it's common, just so you know, if the hold is written out in the field, it's more common to have transportation be done by an ambulance with restraints. And so be prepared. Now, as a parent, that can be very difficult, especially myself having been in restraints on the other side. It could be very traumatic. But you really want to start with the most least restrictive way in which you care for your loved one. Perhaps while you're out in the field, you want to start with a suicide prevention lifeline, which we'll talk about in a minute, 800-273-TALK. Maybe you can go to the next level and introduce the CAT team, crisis intervention team. If that doesn't work, maybe you can say, I'd love to take you in voluntarily. Would you voluntarily come in for care? And even then, if really there is a crisis, at last ditch effort is maybe calling 911 or the police if there is severe danger at play. And so when you come into an emergency department, there are two ways to be admitted into a psychiatric hospital. The first is a voluntary admission, and it's going into a secure psychiatric facility through the emergency room on your own will. That is the best case scenario to do so, because you really want to reduce the risk of traumatizing your loved one when they have a choice and they're coming in. One way I've approached this before is the use of empathy, because your loved one might be struggling in a crisis, and oftentimes in a crisis it just feels like you're out of control. And so you might want to say something like, John or Fred or Juanita, I am so sorry, it just sounds like you're not eating well, you're not sleeping well, you're having a very difficult time. You've been down, feeling depressed, and I would love to see if I can take you to an emergency room for some help voluntarily. Is that something we can do together? I will walk with you. What I want to steer clear of and be very careful is you don't want to be forceful in your approach, because that becomes a source of pain and then becomes a trigger for the future, where you're unable to really walk with your loved one. Involuntary hospitalization, also known as commitment according to 5150 Welfare Institution Code of California, is when a legal document is written to hold a person by a designated evaluator. And so evaluators, again, can be a CAT team member, a peace officer, someone by the county, a mental health professional, a member of the tending staff on the emergency team at the hospital. And basically a hold means that you're now legally detained and unable to leave according to the law. One thing I want to note is that while we have voluntary and involuntary admission here in Orange County in the state of California, that actually applies across the nation. However, the way and the criteria is written around 3-day hold or 2-week hold is different for every state. And so I just want to clarify that for our friends who are online and watching this as well. The driving value behind a hold isn't to really cause more suffering. The underpinning value is really to keep your loved ones safe today. Keep your loved ones safe today. And that safety value is really what drives a lot of the processes and care in behavioral health. And so what you're going to find is that if you are held against your will initially for up to 72 hours for 72 hours for assessment and evaluation, what you're going to find is that only a psychiatrist, once the hold is written, may discharge a person before the 72-hour hold is completed. And so it's not a commitment for 72 hours. You can leave before, but the psychiatrist will have to discharge you accordingly. However, what you're going to find is as you're being prepped and the hold is written, the emergency department will do a blood draw with your loved one or yourself. And the reason for doing this is to determine if there are any substances, alcohol, or any physical problems causing any physical risk or harm. Inpatient units are not set up to provide emergency room types of care. And so you just want to make sure you're, in a sense, medically clear. And so that is the protocol, is basically to make sure that you're clear to transfer to a unit. And if you're being evaluated and you do not meet legal criteria for an involuntary hold, your loved one does not meet criteria for being held, being in the emergency room, and you're discharged, there is some options that you can have going forward. Let me share a few of these, because oftentimes people will just go home not knowing what to do. I just went to the emergency department, and they're not taking my loved one, and Steve talked about this a little bit. Wait a second, I'm begging for help, and I don't know what to do from here. And so let me offer up for you a couple things and ways, options that you can approach this. You do want to explore options for residential treatment programs, partial hospitalization programs, intensive outpatient programs, or other services in your local area as needed. We do have some exhibitors here in the back of tent 3 that we'd love for you to get some information before you go. I will also be covering these types of services towards the end of this presentation or towards the end of today. But if you look at pages 41 on your types of mental health and levels of care in your packet, that's where you can really find a breakdown of what I'm talking about here. You also want to, if you're discharged from emergency department, schedule an appointment with a therapist and a psychiatrist. Doesn't mean you need to have ongoing care, but maybe you want to rule out if there is mental illness, or if not, or if there's necessary treatment that your loved one or yourself can benefit from going forward. Another option is to give the Suicide Prevention Lifeline phone number, which is 800-273-TALK, to all your friends and family involved, including your loved one who has just been discharged. It's a very simple tool, but they have some trained individuals on the other side who can really walk through and listen to what's going on, maybe post-crisis, or maybe you're at risk moving towards a crisis. If you look at page 51 in your packet, you're also going to see the Suicide Prevention Lifeline handout as well with information. Basically, another option is that you do want to increase contact with a therapist if you're already seeing one when you discharge, or with a psychiatrist who is providing care before it moves into a crisis again. So when you discharge, you're seeing someone, you really want to be sure to follow up and make sure that they're increasing maybe the number of times, maybe twice a week with a therapist, to make sure they get that added support as they move through their wellness journey. You certainly want to dispose and secure of any means, which would be maybe medications or firearms. You basically would want to remove any danger. Your goal, again, is to increase safety, and you also want to reduce risk. Now, this is a hard one for, that I think is that I need to talk about, but this option is to notify friends and family to create a 24-hour no suicide watch team, and you do this as appropriate. Perhaps you might have your loved one sleeping in the same room on the floor with you, but certainly you just want to be more aware of this, of that your loved one is not doing well, and that they know that they have your support. They know that you are available. Or if they're a student in another on campus somewhere, contact their friends. If they're living with roommates, contact the roommates and say, heads up, I just want you to know that we'd love for you just to be on watch, secure any means, and remove any danger. So if the person is placed on involuntary hold, once the person has been medically cleared in the emergency department, they'll be transferred to the psychiatric unit, either at the current hospital and or another hospital. And understand that hospital staff are in charge of coordinating the transfer, and oftentimes the transfer to another hospital will be done by ambulance. What you'll find is a chart and the information from the emergency department or room will be going with the individual as they transfer to another hospital. I want to talk real briefly about HIPAA law. This is a very big point of contention for a lot of us who want to seek care, because it becomes a wall, invisible, this wall that comes up when you want access to care for your loved one. Basically, the U.S. Department of Health and Human Services enforces the federal privacy regulations, commonly known as the HIPAA privacy rule, or in other words, the Health Insurance Portability and Accountability Act. So HIPAA requires, professionals like doctors and nurses and hospitals and other healthcare providers to protect the privacy of your health information. However, the privacy rule does not require a healthcare provider or health plan to share information with your family or friends unless they're your personal representatives. So here's the technical part. The provider or plan, and this is in your notes, can share your information with family or friends if you're involved in the patient's health care or the payment for their health care. Your loved one tells the provider or plan that it can do so. Your loved one doesn't object to sharing of the information. Or or using its professional judgment, the provider or plan believes that the patient does not object. And here's how it really comes down to it at the end of the day. For the best results, every healthcare entity, the emergency department, has what you call an authorization for release. And you want to ask that your loved one sign an auth for release of their medical information to you during the emergency evaluation or admission process. If your loved one refuses, you want to ask the staff to continue asking your loved one throughout the treatment in hopes that they will change their mind as their condition improves. So an authorization for release form is this one document, sometimes it's 2 pages. And on that during intake, your loved one or yourself will be asked to sign this. There's a number of lines in there that basically says, and you need to know this, who can I, if I'm the patient, allow to contact me or the hospital? Who can I? And so I might write my mom's name, my dad's name, or my cousin's or my friend's name. If your name ends up on that list, very important, then you have the right and ability to contact the hospital to hear how your loved one is doing. If your name is not on this particular form, the hospital cannot confirm or deny that your loved one is a patient receiving treatment when you call in. And so I'm going to give you just 2 real quick strategies on how to navigate that piece, because when your loved one moves from the emergency department into the unit and you're going home and you call later, maybe the next day, saying, can I talk to my loved one? And you hit this HIPAA privacy law rule wall, you cannot interface with the hospital unless you get your name on that list for the auth form. So perhaps what you might want to do is have someone close to your loved one, like a friend or a cousin, contact the hospital's psychiatric unit and request a staff ask your loved one to add them to the authorization form. And they're going to be saying, oh, I cannot confirm or deny, even though you both know that your loved one is there. They're protecting your loved one's privacy, right, according to the law. But they may go in and talk to your loved one and say, hey, can we add Susie or John, your cousin, to the list? If you are on the list but need another family member or friend on the list who is safe, visit the patient and ask if the additional family member or friend can be added to the authorization form. It's really amazing because the second that name is added to the form, the Red Sea parts in terms of being able to walk and interface with the hospital. I'm going to share why, because there are some ways in which you could really interface with the hospital that will be helpful as you navigate through this crisis. Now, I've talked a little bit about, from the perspective of family member or friend helping or caring or advocating or walking with someone with lived experience. But I think it's important to understand if you are living with mental illness. And I know for many of us there's a lot of pain and trauma and difficulty having walked through a system against your own will. But I'd love to offer up some advice, having been there, having worked with thousands of individuals and families that might be helpful in your journey. First, and this is, by the way, information that I would tell the junior David, having gone through the system when I was not well in my recovery. I'd encourage you to increase your willingness to participate in your treatment and care. I know sometimes there's been pain and things that keep you guarded, but I just love to encourage you, if you could just take a little baby step and take that risk, it might mean progress on your behalf in your wellness journey. Second, I'd really encourage you to be as honest as you can with hospital staff, because the more accurate information that the staff has, the more guidance and care that they can be accurately provide a pathway in your treatment. You also, I know trust sometimes for some of us, like myself included, has been very difficult when you're in inpatient. And so know that a team of professionals are there to assist you. I know that I bring pain from other maybe incidents of having been an inpatient, but that pain is from people in this setting. So in an effort to maybe try and be a little more objective, it's okay to know and believe, at least tell yourself that there are a team of professionals that are there to assist you. And then I'd probably say take advantage, because there are going to be many tools available and accessible to you during your stay in an inpatient unit. And oftentimes I've seen both sides of the story, where people like to go into an inpatient voluntarily and do well, and there are other people where it's very traumatic. Having worked in this setting, I would say for many families, they viewed an inpatient stay as a gateway, oftentimes into kickstarting their wellness journey. So what happens when now you are in a psychiatric hospital? Here's a typical daily routine. You'll have 3 meals a day. You'll have individual therapy. And you can participate as much as you want or as little as you want while you're on the unit. Participation is encouraged for your growth and wellness. We'll have group therapy. You'll have meeting with a psychiatrist regularly. There's medication disbursement done by the nursing staff. And again, that is the medical model piece. You'll meet with a social worker who can help you coordinate care and services. You'll connect with an occupational therapist. And some places have outdoor spaces where some I've seen where you can maybe smoke, or rooms are often shared, just so you know going in, and so you may not have privacy going into an inpatient stay. And so as a loved one coming in, as a parent or as a friend visiting, there are a couple things you do need to know. Visiting hours are limited oftentimes. They're limited in time and the amount of time that you can spend with people, with your loved one. And the rules are fairly strict to ensure patient safety. And it could feel demoralizing. It could feel very humiliating because, first of all, no one wants to be told to put their hands up and to be searched. So some places do that, right? They have a metal wand in the wand juice sometimes. You'll be told that you can't wear shoes with shoelaces. Or maybe your belongings might be searched for objects that pose a safety risk. So be prepared going in and expectant. Your whole goal to visit is really to encourage and be present with your loved one and maybe talk about some of the options as you're getting ready to move towards discharge. One of the key elements that all of us have as an opportunity going into an inpatient unit is that you want to request a family session, okay? So you want to request a family session. And basically, if the authorization for release has been signed, you want to request a family session, particularly with a psychiatrist or the attending psychiatrist of your loved one, a social worker, and also a nurse who is on the team as well. I would recommend that you approach this with being a little polite and collaborative in nature, and there's a little bit of professionalism. I know that oftentimes having and walking through a crisis, you're angry or frustrated, rightly so. But certainly there are a team of people who really would like to communicate with you about what's going on. So to set up a family session, just contact the hospital's psych unit and ask to talk with the charge nurse or the social worker and request that you would love to meet with them to talk about certain things, which I'll go over in a minute, that you want to cover in terms of your loved one's care. I would like to go out on the edge a little bit and even say that there are people on the treatment team who are fighting for your loved one's wellness and stability. And yes, there are nurses and doctors who are burned out or probably shouldn't be there. But there are also others who I've seen who have lots of compassion and care who are on the unit as well. And so here's what you want to ask when you meet with the social worker, the psychiatrist, and the nurse, or a nurse. You want to find out, and bring a pen and a pad of paper if you can, what the diagnosis and what the diagnosis is and what the diagnosis means. And so when your loved one or your friend or yourself comes in, a provisional diagnosis is provided. And just note that this may change during the course of treatment while someone's on the unit. Secondly, you want to ask the course of the illness and its prognosis. And you also want to ask the psychiatrist the estimated length of stay. The estimated length of stay. This is based on how long the psychiatrist believes that your loved one will be there. And it's usually set, again, by the doctor. And it doesn't typically go more than 2, 3, or 4 days. So that may change based on how one is progressing in their care. That's important because you're going to be talking about discharge planning fairly soon during your treatment team or family sessions. And so it's important to know how much time you have in terms of a possible discharge time and date. You also want to ask about symptoms causing the most concern and what they indicate and how they're being monitored. And also you want to find out, what are the medications being prescribed? Why these particular medications, and what's the dosage, and what's the expected response and side effects, and what's the plan if there are side effects? Just so you know, it's common during an inpatient stay to change or have a medication adjustment, as they call it, titrate up or down the dosage or try different medications based on the doctor's assessment during one's stay. And so we'll talk a little bit about what medication will look like when one discharges and how that works. But just note that when there is a med change, oftentimes that means trying something new with new side effects and trying to figure out how do you get the maximum therapeutic value of the medication while reducing side effects, right? And so the whole team is working together to really figure out that place in which the wellness can increase as a result of the medication management. And so if you look at a treatment team on staff, there are some common elements. Here's a sample treatment plan. You'll provide individual treatment, group treatment, medication compliance. You want to stabilize mood, increase coping skills, and eliminate psychosis. That language has been used quite a bit, and psychosis simply means, for those of us that don't know what it is, it just means that you have delusions, which are unshakable, irrational beliefs, and or hallucinations. The most common are hearing voices, auditory hallucinations, and the other common one is visual hallucinations. They have to do with your five senses, seeing things that are not there. Perhaps another treatment plan approach is insight and judgment to be improved. Insight is usually tied to the individual's understanding of what circumstances brought them in, and or at what level do you recognize that you might be living with a mental illness. Another few treatment plan options is to eliminate suicide ideation or monitor and adjust medication, which you talked about. And so your loved one is on the unit, and you're asking the question, how long will my loved one be on an involuntary hold? And I'm just going to talk about 5150 and 5250 real briefly and what that means. There are a lot of other codes that are there, but these are the most common. That's why I'll cover them this morning. The Lanterman-Petrus Short Act of California, or the LPS Act, concerns the involuntary civil commitment to a mental health institution in the state of California. And it refers to sections 5150, 5151, and 5152 of the Welfare and Institutions Code, or WIC. And this bipartisan bill was signed into law in 1967 and went into full effect in 1972. So if you take a look at some of the language I use, as Kay had mentioned earlier, like grave disabled and other language, again, it's not an attack on one's dignity, it's just the language that was used back in the day, so you can understand context. 5150, also known as a 72-hour hold, it is a detention of a mentally disordered person for evaluation and treatment for a period of 72 hours for persons who meet the alleged legal criteria. That's the legal criteria of being a danger to themselves, that's suicide, a danger to others, maybe want to hurt someone else, or gravely disabled, just meaning I'm unable to care for myself due to a mental disorder. If you look at page 47 in your packet, you'll be able to see a little bit more information on this. We also have for children. What is the code for children when it comes to a 3-day hold? Here in California, it's known as 5585. And that's also known as the Children's Civil Commitment and Mental Health Treatment Act. And this is a children's version of a 72-hour hold, and it uses the same legal criteria of being a danger to self or danger to others or gravely disabled. What you're going to find is if you're going into a 5585 with your child, that all the other rules apply past how long you'll stay. So 5250 for longer stays that are applied to adults. And again, that's on page 49 of your packet if you'd like more information. 5250 is basically known as a 14-day hold, and basically a certification for intensive treatment for another 40 days on top of the 3 days that your loved one or yourself were there, means that you've met criteria, and so therefore are going to stay for up to another 14 days. And just remember that a psychiatrist can actually discharge you before that 14 days. There is something called a certification review hearing that will be done once the 5250 is written by a psychiatrist. So you're in for 3 days, you're still not doing well, and so you need to stay longer. A 5250 is written. Within 4 days, a hearing needs to be done. And what it is, it's known as a probable cause hearing, and it's a facility-based hearing for persons on a 5250 or 5257 hold, which is a longer hold. And the hearing is to determine if the psychiatric facility has probable cause to keep the person for the remainder of that 14 days. When a 5150 ends and 5250 is written, you're going to hear basically a few things from your loved one. You're going to find out that they're invited within 4 days to sit down at this review hearing. And it's not like in a court setting. Basically, there are typically four people in a conference room that's private. When the hearing is done, it's going to be a hospital staff representative, a psychiatrist or a social worker or a nurse. It'll be your loved one or yourself, right, if you're in there, with a patient advocate who will meet with you typically before to hear how you're doing and what's going on. And then you're going to hear from a county representative. In LA, they call it mental health hearing referee. Here in Orange County, they call it different. But the whole idea is you're in here together. And when you sit down, real simply, the hospital staff will share their perspective of what they're seeing clinically. And then the patient advocate and your loved one will share their perspective of how they're doing well. And the person who's kind of mediating it will make a decision on who's going to basically win in terms of probable cause. So if your loved one wins their hearing and there's no probable cause determined to keep the individual, then they'll be given the option to stay voluntarily. Most times than not, the person will go, and they will discharge against medical advice. In language of the hospital, against medical advice. We prefer that you stay, but oftentimes, if you're a loved one and you're in there, it really just kind of depends. It can go either way. It just depends on how well things are going in terms of medical necessity. Now, this is very important because now, while you're there in the facility, you're getting ready to move towards discharge, and you're receiving care. You're hopefully going to maybe some of the treatment services like group and individual, and you're finding that you're getting ready maybe in a few days to discharge. Just this is very important. This next slide, because a suicide rate after a discharge, according to a study of 100 studies, so this is a meta-analysis, found that the suicide rate was approximately 100 times the global suicide rate in the first 3 months after discharge. And so sometimes there's this illusion like, oh, my loved one is going to be fine if they go in and they leave. But I'm going to talk a little bit about continuity of care and how very important it is to continue the care, because the journey may be longer than you think. And so we'll talk about what your treatment options are post-discharge. A couple things. You want to have an aftercare plan post-discharge. Continuity, and I'm going to say this again and again, continuity of care is the goal. Between every transition between an inpatient unit to another level of care, you don't want people to fall through the cracks, your loved one to fall through the cracks. Continuity of care is very, very important. Keep the momentum going in one's wellness journey. See, myself, I had 6 relapses over 7 years. I'm living with schizophrenia. I still take medication. And I think if you know this and what I'm teaching you this morning, I believe it could really reduce the amount of suffering if you have a plan and really recognize the need for continuity of care, because my parents didn't know what to do. My friends at school didn't know what to do. I just got plopped out to outpatient care, and I had no clear direction. And so this is going to be very, very important that you understand some of these concepts. I'm going to talk a little bit about the law and firearms as it is relevant to this training. If you've come in and an involuntary hold for 5150 was written for danger to self or others, according to California law, that's section 8103F, you will be prohibited from possessing or acquiring firearms for 5 years after your release from a psychiatric facility. There is a new law coming in January next year, January 2020, AB 1968, and a person would be generally permanently prohibited if you're admitted to an inpatient psychiatric hospital more than once within a 1-year period. And so what about a 5250? If you've been certified and there was probable cause to keep you, the law says in California that you would be permanently prohibited from accessing or acquiring firearms for a lifetime. The only way to get around that is you could petition a court to restore your firearm access, but then that's on a case-by-case basis. Generally, what happens when you're admitted into an inpatient unit is the staff will make a report to the State Department of Justice. It's an online piece, and provide information just to make sure you're in the database. And so restricted firearms, anticipate that if that's something that you value, enjoy as part of what you do in life. Now, we're going to take a 15-minute break. There are refreshments in the back of the tent, and we're going to come back in 15 minutes and talk about post-crisis and what that looks like. And then we're going to, after I talk a little bit, we're going to go ahead and we're going to jump into some Q&A with our team. Okay? That it's common and encouraged for family or friends of loved ones on a unit to research these programs that I'm going to talk about before the discharge happens. That way you're working with the team at the hospital to determine, and your loved one, which next level of care the person can go to. Imagine, as I talk about this in a moment, a few things. Imagine like a triangle, and you're in the at the very top with acute care, and then you're going to step down, which is a language, to a lower level of care. So it doesn't require as much structure, as much intensity, as much resource, but there is some level of care being provided. As you go down the triangle, you're really going into and landing on at the base, which is outpatient care, and we'll talk about those pieces. Again, continuity is your goal during a transition from inpatient to another care. And you want to make sure that your loved one gets their prescription filled and are supported in making appointments after discharge. If you take a look at the discharge paperwork of your loved one, it's going to list out all the medications that are there and what dose and how often you could, or they're going to need to take it daily. And so you're going to see that information. It's important that you take them in as soon as possible to the local prescription or pharmacy place where you can get the medications. So you have that continuity of care. Make sure you support your loved one, because they will also have either one of these levels of care I'm about to talk to, or at a minimum, insurance requires that psych hospitals have your loved one make an appointment with a psychiatrist or therapist before discharge. Or if they're, again, going to step down into a partial IOP or residential treatment program. And so that continuity of care, that encouragement, that support, making sure that your loved one makes it past that gap in that transition is much, much needed if you want to continue that momentum. Another thing I would like to say is that you want to be sure to get a copy of the medical record. And this is important, and this is something after discharge that you can request. Some hospitals pay, I think it costs like $25. It might be more for others. And one of the reasons you want to get the medical record is you want to be sure to get that into the hands of the treating psychiatrist post-discharge. So maybe there's an outpatient piece where your loved one was seeing a psychiatrist already, so that they can make a better informed decision on how the care and the treatment is provided for your loved one going forward. So if you look at the behavioral health continuum, you're going to see what we call a continuum of care. And so like a triangle, here's another picture in terms of continuum. On the far left end that you'll see, you're going to see inpatient care, inpatient psychiatric services, where you're going to find severe symptoms, including criteria that we talked about. And then you would step down, possibly, to an outpatient partial hospitalization program. And these are often known as full-day programs, and symptoms are starting to reduce. And imagine taking partial and cutting that in half. And what you'll find is called an intensive outpatient program, or IOP, or a half-day program. And then when you see the green segment called recovering, that's actually back in being in outpatient care, typically, again, seeing a psychiatrist and a therapist for ongoing cares. Though I must mention there are a lot of other types of care. I'm just talking about some of the most common ones. As you see, there are exhibit tables in the back. The county, for example, if you have Medi-Cal insurance, in other states it's called Medicaid. They have county-based services that you also can look into at every level of care. Now, a partial hospitalization program is ideal for people who are stepping down from inpatient and need to continue their recovery. I liken this to where you were in a crisis and you just stepped over that line to being at risk in your circumstances and what's going on. And people may be experiencing a decline in their ability to with their symptoms. They might still be isolating or expressing suicidal thoughts, but have no plan or intent. And so there's still a lot of struggle going on. You just came out of an acute inpatient setting, and individuals could be stable, but maybe using unhelpful coping strategies, such as maybe self-injury like cutting, or self-medicating with substances in response to some of the stressors, school, maybe work, or pain that might come from a loss, or maybe things going on with their mood. And so basically, you can contact any partial program in your area to determine if your loved one is eligible for care. And I'm going to highlight that word eligible. It's very important. You could ask your social worker in the inpatient unit to provide referrals or assist in the transition from inpatient to a partial program. And the social worker can also work with you to help determine level of care and how to get access to some of the options for partial programs. Note that collaboratively, the social worker and yourself could work with your insurance company to gain authorization for treatment before discharge from the inpatient unit. So generally, the day of discharge, say it's on a Friday, they may start Monday, as soon as Monday. The shorter that period of time, actually the better, so you can have that ongoing care. PHPs are partial programs, refer to outpatient programs that patients attend for 6 or more hours a day, every day or most days of the week. And these full-day programs are pretty packed. Oftentimes they provide food during the day, and you're living at home. And so partials do vary by model. Generally, they provide substance use, psychiatric, or dual diagnosis. So if your loved one is coming in with substance use and has gone through a crisis, there are partial programs that specialize in treatment with substance abuse. If they come in for mental health only, there are partial programs that specialize in mental health. Then there are partial programs that specializes in both, dual diagnosis programs. And so you want to make sure when you're looking at your options to see what kind of program the partial hospitalization services provide. They are less intensive than inpatient hospitalization, and they often have group therapy, educational sessions, individual therapy, as well as family sessions. Many of them have a psychiatrist as well that's working with the team. And during this transition, I will say this, whereas being in an inpatient, you're involuntary, going in a partial, you really want to be collaborating with your loved one in terms of participating in their own care and encouraging that support and in their wellness journey. That's when you know that according to research, one's motivation is really tied to some of the wellness outcomes that are out there. A partial program may be part of a hospital services. Locally, we have Mission Hospital Laguna Beach, for example, and they have a whole host of partial and IOP programs. Or you may go to a freestanding facility that provides partial services as well. Each person will be assigned a case manager or individual therapist who works with a treatment team. And they make recommendations based on the progress your loved one is making. Here's a point I want to make about partials. Transitioning into a partial hospitalization program does not mean that everything's back to normal, but it is a step in a direction of wellness. And again, I really want to emphasize, continue that support. One of the biggest challenges, by example, that I've seen is people don't know how to get there. They don't have transportation to get to the programs that are post-discharge. Figure out a strategy or a way to make sure that your loved one gets supported and brought so that they can continue their care. Again, you don't live at a partial hospitalization program, you live at home, and basically they'd be coming from the residence for care. Next on the continuum, you're going to see intensive outpatients programs. Now, while I'm showing you this continuum, it must be noted that when you move from a hospital program, an inpatient psychiatric unit, sometimes people have gotten well enough where they can discharge to an intensive outpatient program or even discharge to outpatient care with a psychiatrist and therapist referral. And so this is really just kind of like, again, the acute care paradigm I'm showing you with a triangle. Intensive outpatient programs are ideal for stepping down for a partial hospitalization program. So again, imagine partial being cut in half. They basically focus on reinforcement of coping skills, strategies for relapse prevention, and the goal is really to get the person to transition back into daily life, at home, at school, at work, maybe the relationships that they had. And just to note, some IOPs really have a heavy focus on psychoeducation, which basically means learning on how to manage and cope with mental illness. So you'll find they're less process-oriented or counseling-oriented and more focused on education, and here is how you can manage and cope. And so the report from your loved one, if their expectations is to go deep and to go wide, but they get education instead, there might be a frustration. So just be sure that you understand and are asking the IOP program or partial programs, what services do you provide and what does that look like? IOPs are similar to partials. They're half-day programs, and they're usually 3 to 4 hours long, and patients will attend anywhere between 3 and 6 days per week for a limited time in the morning, usually like 9 to 12, in the afternoon from 1 to 4 or 5 or 2 to 5, or maybe an evening session. And again, like partials, IOPs can focus on substance use only, mental health only, or again, both. Some of them, not as much, will do dual diagnosis. IOPs are part of the hospital services, again, or they can be freestanding apart from a hospital. Every program is different, and they're tailored to the needs of the individual and the type of concerns that are being addressed. At this point, I've seen many individuals being able to work, and so perhaps they're going to an evening session 3 times a week. And the hospital staff, just so you know, will be working with insurance to see how many days of authorization you can get for partial. For example, stepping down from an inpatient unit into an IOP, you may get 15 days of IOP, meaning 3 to 6 p.m., and you get to oftentimes pick those days going into IOP based on your schedule. Now, as we move down the continuum of care, we're going to now go into outpatient treatment and continuum care. This is after the hospital support And this is when you're living at home and you're basically not in an intensive setting. And your loved one may not want to have information related to their care at this point given away. And so, we did talk about the authorization form in the inpatient setting, but, how this applies to outpatient treatment is that outpatient treatment basically involves office visits with no overnight stay. There's a combination of seeing a psychiatrist and licensed therapist, which really is one of the best models in terms of practices. And it'd be great if you can get your psychiatrist and your therapist to talk to each other to coordinate care. Now, that'd be a grand slam. That'd be a best practice. But at that point, if your loved one does not know of this option, you might want to encourage them, because oftentimes at this level, and it's different with every family and dynamic, the individual doesn't really want their family member knowing what's going on with their outpatient care. And if they do, then the signed release, you can say to your loved one, hey, here's this, you might want to get a signed authorization release so your psychiatrist, as an option, can talk to your therapist to kind of encourage that collaboration. Because in the bigger picture, it's not your loved one walking alone. They're really kind of at the helm. Think of us, at this point, a round bicycle wheel. Your loved one is in the middle, maybe with yourself, and these spokes lead out to a team of individuals who are supporting your loved one in their wellness journey. It could be professional care, like IOP, partial, psychiatrist, therapist. It could be informal care, the church. It could be friends. We know, according to research, that family is can be one of the greatest assets in helping people walk in their journey as you come together. So just remember that you're building a team with your loved one, or if you yourself are living with mental illness, you're the one that gets to steer the ship. And you're the one that gets to walk with others in really this journey so that you don't have to go alone. Some outpatient settings are based in community health centers. They're located in hospitals with outpatient clinics. Many are private practice offices with a mental health clinician. The key here when it comes to professional care is that the person here in the state of California is licensed. So you have psychologists, you have counselors, you have licensed social workers, licensed therapists. If you're coming from an inpatient or partial or an IOP, you really, again, want to encourage your loved one to take baby steps, because as you move through this kind of continuum of care, the experience for myself and others who've gone through it is it just feels very overwhelming. So it can feel feel like there's little hope. It could be very discouraging. And so rather than having a forceful approach, or an approach that says you need this, this, and this, and this, and this, and this, and here's a plan, just remember, take little tiny baby steps of compassion. Little tiny baby steps of encouragement, little tiny baby steps in how you lead and walk with someone who's been impacted by mental illness. I am going to talk about something that is not on this paradigm here. It's a residential treatment center as another option. This is more of an anomaly outside our general system of care. And residential treatment centers usually provide care for 30 to 90 days, more 90 days on average. Stays may be individualized according to each facility's policy and extend past a year when medically necessary. And they do as well provide psychiatric or substance use or both dual diagnosis. Residential treatment centers, bottom line, are very hard to access, and that's why I put that last, because eligibility is based on insurance. Or what your insurance can do, or its eligibility is based on private pay. Oftentimes, it can get rather expensive. I've seen locally, and I'm not sure how it is nationally, Medi-Cal, or nationally is Medicaid, often does not cover residential treatment care. Usually it's a county office like here, county services, where we have adult mental health services here in Orange County. If you're looking for a Christian residential treatment center, maybe have an ability or eligibility for this, we use here at the church often is lighthousenetwork.org. That's lighthousenetwork.org. And just so you know, it's not uncommon to travel across state lines to receive treatment from a residential treatment center for your loved one. Basically, just picture your loved one living on the premises. Oftentimes there are houses, really beautiful houses with rooms in them and a common dining area with someone who lives on the premises. You attend various group and individual therapy, work with a psychiatrist for medication management. And really, it's just focused on creating new routines that help support long-term recovery. Now, we're going to be able, if you have any questions related to this system of care, please go ahead and write down any more questions that you might have, and we could transition here in a Q&A in a moment. Now, what I want to address real briefly is, what do you do if your loved one is not getting good care? In the emergency room, in an inpatient facility. You're hearing horror stories. And it's just terrible, as Kay talked about earlier this morning. There are steps in which you can file a grievance because you do have rights. You do have rights as advocates, as parents. And I'm going to show you 5 steps today that you can take to really move in filing a grievance. The first step is to share the incident and current concern with the hospital staff while your loved one is there. And so this is very important before you can get to step 2. You want to contact the charge nurse and let them know what your concerns are. And if not satisfied, the unit manager. And if not the unit manager, you do want to contact the administration if there's no solution. And your goal is real simple. It's to determine what can the hospital do to change or ensure a solution to your concern. This step should actually get you the quickest response because there's a lot of dialogue that happens internally. And be sure to document what measures, your conversation, the times and things are being taken to ensure quality of care and safety. The second step, if you're unhappy with the interactions with the hospital, is you can call the patient rights office here in Los Angeles. The phone number is 213-738-4888. And having exhausted your time in talking to staff at the hospital, to no avail, they may launch an investigation in partnership with the Department of Mental Health. Now, you can also call them if you just have any questions, too, related to what rights you have for you and your loved one when it comes to the care a hospital is providing. And so you can also call that 213 phone number as well. Step 3 is the family may also submit a grievance with their insurance company, who also has their own protocol for handling quality of care issues. Sometimes when you get your insurance involved in terms of submitting your concerns, it could invoke a quicker response or solution while your loved one is in the hospital. Your insurance has what you call a utilization review person who is in contact with the hospital about the clinical situation of your loved one. And they're talking back and forth on a regular basis about how much authorization can be provided in terms of days of stay. And word oftentimes gets wind, the insurance company gets wind, like, wait a second, this care is not being well. The family requested a family session and it's not being provided. So they're talking to the hospital saying, why isn't this being provided? What's going on? And they're looking to try and solve the problem behind the scenes. Another option, step 4, is to submit a grievance with the hospital itself. And this is different from the step 1 in terms of calling the charge nurse or other staff. The hospital, you can contact the hospital to determine how to submit a formal grievance, or you can check the hospital's website for information on how to do so. It can be very empowering to have these options because sometimes I've seen you just feel so helpless, especially when you hear about some of the care that's happening with your loved one. And an investigation will occur according to their protocols if a grievance is submitted, and oftentimes they'll provide you with the results of their investigation. If not, you can ask for it. And the last piece, the last step, is you want to submit a grievance to the hospital's licensing and accrediting bodies. Now, this is more of a long-term approach, and this is where you're ready to fight back because now you have more strength, because oftentimes you're just pulling from every area, spiritually, emotionally, relationally, to try and get to a point of walking with your loved one to a place of being well or being in a stable place. And now you've got some rest behind you and some hope in the picture, a little more. This is where you can advocate and you can contact the hospital's licensing agency here in the state of California. It's the State of California Department of Healthcare Services, and you can call them at 800-228-1019. And you can also contact their hospitals are accredited by JCAHO, or Joint Commission on Accreditation of Healthcare Organizations. And this is the really big, if you would, accrediting body of hospitals. You can report an event as well with the Joint Commission on their website, or you can contact them, and you can move that process forward as well. At this time, we're going to transition into some Q&A with our team. Kay and Steve Pittman will be coming up, and then hopefully we can get to your questions very, very quickly and give some answers. Sure.
Let's give David a big hand. That's great. Thanks, Christina. Thank you. And I'd ask Christina to join us too.
Yes.
And we have another mic there. Thank you, Steve. All right, so you've written some questions, and some of them have come in off of the online as well. But so these are not in any particular order, so they're going to be a little all over the place. Oh, sure, why not? Oh, see, I told you we might be here till 5 o'clock. Thank you. Okay, few more. Oh, wow. Okay. Now you're going to have to give me a second to look through these. Sometimes people ask really strange questions. Like at a mental health event, the question is, why did God put 2 pair of all the animals on the ark? Not kidding, I got that one once. All right, so I'm going to start through these, but I'm going to give you a question, and then we'll come back to these that I just received. Okay, so this one really just goes with what I think you just covered, so you might just refer back to that. But it says, when you have been in an involuntary hospitalization in your past and were sexually abused while you were there, how can you make sure that you are safe and treated correctly and safely by both the ER staff and the psych hospital staff? Some of that might go along with the grievance thing, but anything else you want to say on that, David?
Yeah, first of all, I just want to say I'm so sorry that happened. That is just terrible. And, that can be very traumatizing. And I'd encourage you, as a step, if not already, to go in for some care where you can work through that, journey through that pain with a professional, licensed professional. When it comes to ensuring patient quality care and making sure that you're not sexually assaulted as this incident had happened, each of us have a voice. And oftentimes it could feel very discouraging to see a system of care that is broken. There are people who probably shouldn't be providing care in all these levels of care. And there are people that certainly should be there as well. And so when an incident happens right away, you now know what your options are. Because I've seen when someone says to a social worker or someone on the unit, we're going to call the patient rights office in LA, the mood totally changes. And the direction changes as well. So you do got to know what your rights are so you can avert and resolve any issues that are there. So.
All right, several questions have come in about the partial hospitalization and the IOP, and one of the questions was, I'm wondering if there was a mistake on the slide, because somebody asked, because it's partial hospitalization program, but one of the slides said PCP. Was that just an error?
That's a typo.
That's a
an error.
typo.
That's an
That is
error.
not a new kind of care. It is partial hospitalization. Yes, I thought so, but I wanted
Well,
to just make
if we
sure.
want to create a PCP, because we need more resources out there.
That's right.
We'll take it.
Patient care. I'm not going there. Okay, but anyway, okay. And then the other question that was coming in about PHPs and IOPs was, can you only access those programs through inpatient?
No. So I did talk a bit about if you go into the emergency department and your loved one is not accepted or admitted into the unit, the inpatient psychiatric unit, and they're discharged from the emergency department, it is strongly encouraged for you to begin to look at maybe a lower level of care so they can access, instead of an inpatient unit, maybe an IOP or maybe a partial program. And to do so, just contact their any IOP or partial and ask them, hey, this is the situation with my loved one or myself, if you're calling on your own behalf, because you're advocating, and say, do I meet criteria or eligibility? And so they'll begin to walk you through a stream of questions to help you determine the best fit.
Okay. Yeah, I'm throwing these not because they're not good, but because we just talked about them. And that way, yep, we talked about that. This is a totally different idea, but it is this is the question, how do you convince a loved one to do a conservatorship and or power of attorney to handle his or her affairs? That is a really big question for parents with adult children with serious mental illness. Steve, anything you want to say on that, or Christina?
Yeah, I was a conservator for my brother on several different occasions. The thing you have to understand, number one, is that if you go through that process, and it's a legal process, your family member is going to be represented by an attorney, a public defender. And the public defender, in most cases, are going to be doing everything they can to prevent the conservatorship. So you just need to brace yourself. You also need to be prepared that any documents that you file, moving in the direction of conservatorship, will probably be shared with your family member. So generally speaking, David said on a number of occasions that you need to advocate gently and in a positive way, and that's the way I would approach this conversation too. In other words, it's not something that we're going to do to you. The question is, how can we best help you get where you want to go? And if he or she starts to frame it in that light, the chances of it going through are significantly better.
When would it be advisable?
Well, I commented earlier, I said you have to understand most of these folks are very bright, and most of them can present themselves very well when the need arises. So if they think they're going to lose their rights, as the way they see it, they'll present a fairly compelling case that they should not. I can remember my brother was in the hospital once, and I raised the question, don't you think he should be conserved? And the gal that I was dealing with said, well, no. And I said, well, why not? She said, well, he lives in his own apartment, and he prepares his own meals, and he's in control of his money. I said, where did you hear that? And she said, well, from him, from John. And I said, well, let me give you a few more of the details. Somebody else comes in and cleans his apartment once a week. Somebody else takes all the dirty clothes out, washes them, folds them, and puts them away. Somebody else writes all of the checks. And they said to me, well, we didn't know that. And I said to myself, did you think a 60-year-old man was going to tell you that? No. So a lot of times the issue is a lot of folks need more information, and it needs to be presented kindly and positively so that the system can respond in the same way.
So this is around that same idea of family members having information that perhaps the mental health professionals have not had access to. How can, when you're finding that impasse as a family member with information that you feel like the treating team needs, and maybe your loved one is not as interested in giving you permission, how does a family member, a spouse, a parent, a brother, a sibling, whoever is helping out, how do you get information to the mental health professionals that probably they really do need? Christina, what would you say to family members? I haven't introduced Christina to you. Some of you know Christina. Just introduce yourself briefly, Christina. I'm sorry.
My name is Christina. I work here at Saddleback Church on the Hope for Mental Health team alongside of David. I have some experience working in partial hospitalization settings and in private practice, so I'm here to support. Okay, so getting information to the clinician that might be treating your loved one, it's a tricky thing, right? Because there's confidentiality, and we want to really honor that person's story and what they feel comfortable sharing it. Always. That is always number one priority. I think over time, if we can build trust with our loved one and say, if you'd ever like for me to be a part of this journey with you, and you want to bring me in, if you want to bring me into one of your sessions, or would you like for me to talk to somebody sometime? And I think that would be the ideal approach. I might be working with somebody and I say, hey, if you have any family member that you want to include in your treatment, let me know, because they're supporting you all throughout the week, and I only see you 1 or 2 hours a week. So I think on both sides, hopefully the clinician is supportive in that manner, and then if you can build trust in that way with your loved one, I think that would be the ideal situation.
Anything? Yeah.
The other thing, David addressed the fact that you can restrict a HIPAA release to certain named individuals. You can also restrict it in terms of what information can be shared. And the thing that I used to tell both my brother and my granddaughter is, I don't want to know your deep, dark secrets. I don't want you to know mine. What I want to know is I want to know what the diagnosis is and what I can do to help. That's the end of the story. Oh, well, if that's all you want to know, so.
And,
Go ahead, Dave.
and also for an inpatient setting, and perhaps your name is not on that list, how do you get information to the hospital staff? I'd encourage you to call the hospital psych unit, ask for the nurse, and ask for this fax number. And they cannot confirm or deny that your loved one is there, but just say, I'm going to fax you some information to go into my loved one's chart, and use their name. And when you fax information, be sure that it's legible, that it's clear, and one page. One page. It probably won't get read if it's real long, 15 pages of history. But if you have something like their portable health record, by example, that you have in your packet, that would be wonderful in terms of helping the process move forward. And they'll get it, and they'll put it in the chart for everybody else to see. But it's like playing a game. Oh, I cannot confirm or deny. Yes, please. I really need that information. But they'll give you the number to fax it over or email.
Yeah, as a family member, Matthew would go in and out of willingness for us to be a part of his treatment or not. And so I just got good at playing a game, which was when the psychiatrist would tell me I can't, I don't have permission to speak with you, then, but I had the psychiatrist's email. And so I felt free many times to just send in information, as you say, fax information, email a psychiatrist, leave a voicemail on his or her phone, knowing they couldn't respond to me, but that didn't keep me from filling in, at least some other backstory. But I appreciate the reminder to keep that succinct, because those of us who've had family members who've been ill for a long time, the list of their treatments and what they've gone through and what they've experienced, that file just keeps getting bigger and bigger. And, a treating doctor is not going to be able to wade through most of that. And so just the idea of keeping things succinct feels like it gives us a greater chance as family members to be able to convey information, as long as they know they're not going to listen to a 20-minute voicemail from us, or receive a 10-page email from us. As family members, keeping it short, keeping it sweet, keeping it down to the pertinent details. So then somebody asked, I think this is a fairly quick one, what can you suggest particular treatment that might be effective for someone with chronic suicidality? Are there any treatments that you would say that you've heard or experienced that someone who has frequent thoughts of suicide?
If you could find a licensed therapist, each therapist that is licensed has what they call clinical orientation, or the way that they ascribe to providing their care. Or what they call a theoretical orientation, which are research-based. How do they provide care for the individual? One commonly known way of providing care with chronic suicidality, being that the individual is voluntary and willing, right? In their care is DBT, dialectical behavior therapy. I'd also look into perhaps motivational interviewing, which is another way in which you lead the individual if they are resistant to any kind of treatment or care. It just helps lead the individual in a way that helps them maybe move towards acceptance of treatment. I'm hearing a theme a little bit in our questions about, what do I do if my loved one doesn't want care? And so if I can just briefly this is called the trans-theoretical model. It sounds fancy, but really, if you Google this, it's the stages of change. And so instead of change being a yes or a no or a black and a white, this is used actually in a lot of hospitals as well, is where's this person in terms of how they view change? Are they on one end of the spectrum that says, no, I don't care, I don't want change at all, and I may not even know I need change? The next step is on that continuum is, maybe I want change, maybe I don't. So there's this kind of like ambivalence that's there, where you use education, information, exploration, to help kind of decide. Then there is, I'm planning to get change, let's make the appointment. And then there is maintaining change, right? Maintaining what your care that you're receiving. And then there's relapse. And so when you think of your loved one in terms of receiving care, think of, well, where are they at on this place? It's not a black and white, where are they at? And how can I see them take that baby step to that next stage? And it's certainly something worth looking into. And a trained licensed therapist would, in motivational interviewing, would know how to really walk through these stages well.
Several people have asked some variation on the theme of, my loved one does not seem to understand how ill he or she is. Some of them talk about schizophrenia. Some of them also just talk about the person just thinks they keep losing jobs just because they're forgetful, or that they're having trouble in relationships, but they don't seem to understand that there is, illness involved, and what do you do? How do you start making, Steve, you had a lot of experience with that.
Because I've been down this
Yes, road. Of course you have.
My brother suffered from anosognosia, which means you have a complete lack of awareness, the fact that you need some help, particularly in terms of mental illness. And I always responded to that lack of awareness by, I just need to give you some more information, because John was plenty smart enough. And I finally concluded that I could give him an encyclopedia full of facts on mental illness. He could read the whole book, and when he was finished, he'd look at me and he'd say, Steve, I'm really okay, but I'm terribly worried about you. And with that, push all of his meds. So some of you may have missed it, but about 2 months ago, the LEAP Institute was here, that was started by Javier Amador. It is an excellent, and it's also a counterintuitive way of working with someone who perceives that there is not a problem. It's not what you'd expect. He's written books, but I would direct you to a YouTube video called Shut Up, Listen, and Win. It lasts 23 minutes. You all have 23 minutes. But it gives you a different way to approach your family member when they lack that awareness that in many cases is extremely productive.
And I'd also go to kwarren.com/community. And on that, you will find the community education portion on how to help a loved one accept care from Amador's team. He led a presentation on that.
I don't know if I was looking at the questions. I'm not sure if either of you mentioned the particular book that Dr. Amador wrote. It's called I'm Not Sick, I Am Not Sick, I Do Not Need Help. Excellent book. Excellent book for any of you that live with a loved one who does not seem to understand that they are ill. This was an interesting perspective. As a psychiatrist, I want to know what you find most helpful from your interactions during your mental health visits. So there's a mental health professional. Thank you so much for asking that question. I love you already, because it tells me that you really do want to help your patients. So as I can tell you from my own experience, and then the things that Matthew told me, and then I'd love to hear some of the things you would say. Matthew, after years and years and years of so much psychiatric care, and got to the place where he had very little use for any of it, I asked him to make me a list of what were the things that he would do differently if he had the opportunity, if he were trying to treat someone. And his number one, hands down answer was, if the therapist or psychiatrist is not a person of compassion, get out of that field. Because compassion and letting me know that it was important to him to know that the therapist had also suffered. He needed to feel like he wasn't the only person who was suffering. And if he didn't feel like the person that was trying to help him also clearly had experienced suffering, knew what agony and torture of the mind was, then he didn't want to listen to them and feel like they had anything to say. So I can't overemphasize, and in some ways that's not something you can teach. That's not something you can learn in school or in your training. But if coming from that place of deep compassion, and the second thing is treating and looking at the person sitting opposite of you as a human being, as the dignity of this is a human being that I am talking to here. This is not a patient, you're not a number, you're not somebody on my list of appointments today, but you are a human being worthy of dignity and care. Those two things, to me, are the most powerful.
If I could jump in on that.
Please.
It's such an important point. People ask me all the time, so what's the best psych hospital in the county? The best one, because that's obviously where I want my family to go. And I tell them over and over again, my family members, my brother and my granddaughter, had great experiences at every single one, and they had horrific experiences at every single one. And the key to the whole thing seemed to be whether or not the person they were dealing with cared. There's a psychiatrist who I won't mention, but he's very well known in the county, does lots of diagnostic work before he ever begins to prescribe anything. And I know a family that sought him out, had been through the whole process, and they were in the kind of the final, let's bring all this together and decide what we're going to do. And so they're sitting apparently in his office, mom and dad, this young man and the psychiatrist, and going through these reams of information that they've collected, which was very informative. And at a certain point, for some reason, not understood by the mom or the dad, this psychiatrist stood up, walked over in front of this young man, grabbed his hands, almost knelt down in front of him, and said, I can tell this has really caused you pain. The mom walked out saying the most valuable thing she'd ever received from any practicing physician in the county in all those years was that brief interlude. So I can't say enough. That's where it all starts, folks.
And if I would say is, I've been tremendously wounded by psychiatrists in my wellness journey, because I go in and they spend about 20 minutes asking me questions, and then they write up a diagnosis and give me a bunch of medication, you're left to go. There was a lack of relationship. And looking back and looking at the research, one of the most prominent reasons people continue care with a psychiatrist is because of the relationship that they have with a psychiatrist. And so I love that the doctor who's here, the psychiatrist, asked that question, because what I'd love for him and others to know is that, for people with lived experience, is that if you have a terrible experience with a psychiatrist, it's not a reflection of all the psychiatrists that are out there. Don't project that on, don't throw the baby out with the bathwater if you're receiving care. And so my encouragement to you is maybe it's like trying on a new pair of shoes. There's some great workers out there, licensed professional in the field who are tremendously compassionate. And the other side of the spectrum, on the opposite end, there are people who just shouldn't be there. But you want to continue your care. It's like finding a good heart doctor. You want the best that's out there. And so you're going to continue trying. Don't give up. Don't give up.
Christina, you had something. No, please, go ahead.
I think just real briefly, if knowledge could heal, I could just throw a book at somebody, be like, read this, and people would get better. I believe healing is carried in the context of relationship. Relationship is a container, and there might be helpful information that I can carry, but if I don't have compassion, grace, empathy, genuine care, how well can I really carry that, and how well can the individual receive it, or me on the receiving end? If I can tell somebody cares, my heart is wide open to listen and to receive. So I think genuine care and compassion, which is often rooted in our own journey first, is, I think, the greatest gift we can give.
Totally agree. Thank you so much. One question about the school district. Question is the school district able to help with a child affected with mental illness? And how do we educate children with support of the district, I think, or without the support? Anyway, question is, how can the school district be a part? How can school districts help children, living with mental illness? What have you experienced in that area?
I'll take a quick look at this. I think if you're working for a school district, it's very important that you become knowledgeable of what's available around you. Because the more knowledge you have of resources, the more effective you can be in getting people access to care. And oftentimes what I've seen here in Orange County is a level of collaboration, and I know Kay is very involved in some advocacy efforts here at the county level. But I must acknowledge, at least within my limited experience, that schools just don't have as many resources as they need for mental health care. And so as a personal advocate working for a district, you can affect people around you just by being aware of what is available, what are some of the options, what do I need to know, what keeps a person from getting care, and how to get care. If you know those simple things, even if it's just a list, you can begin to affect change.
And then quickly, just because we have time for a couple more, can you, this is a big one, talk or suggest how to navigate through insurance, the insurance piece? Because, we'll just kind of throw that one in there. For hours, exactly. Hold a seminar just on insurance. What do you want to say? Anything about parity or parity laws?
Robert Kennedy
Yes?
has a foundation that he started. Patrick, I'm sorry, thank you. They're all the same, aren't they?
So many Kennedys.
Yeah. Patrick Kennedy started a foundation that deals specifically with mental health and parity for addictive disorders, because even though we have the law, and in California we've had the law since the mid-90s, the Affordable Care Act kicked it in on a federal basis, that mental health conditions and addictive disorders are supposed to be treated like everything else. Well, we already know that that's not true. And so if, folks, you don't complain, the elected officials are going to think, well, we've taken care of that problem, let's move on. And it's just not so. So the different ways that you can grieve if you're not being treated fairly, you can go to the Patrick Kennedy website, you can file there, and then at least everyone knows that we haven't solved this problem yet, because we're not there. But you've got to push the ball forward. You have to understand that the school district, just like an insurance company, is going to start trying to save every dollar they can along the way, which means releasing your family member as soon as they possibly can, and in the case of a school district, not providing needed services. So you have to become the best advocate your family member has.
You can go to parity.org. is one place that you can go, like if you feel like your insurance company has denied a claim inappropriately, and that's a place you can record the stories and all of that and find more information about how to advocate for parity to be enforced. It is on the law. I mean, it is on the books, but it's not enforced evenly. And I think we're going to end with this last question because it kind of brings it full circle. How do you come to terms, someone says, with using psychology for mental illness instead of the Bible? Well, first of all, I'd like to just make sure that you understand we're not saying any such thing. Because we believe that and please kick in here too, but we believe that the Bible reveals us as whole beings. We're body, soul, and spirit, and we need input and help at every level of who we are. And the brain is part of the body, and so the brain can malfunction or function differently than someone else's and create some problems for us. And so to treat the brain as part of the body only makes sense. At the same time, we are souls, we have a spirit, and so we need spiritual input and care and knowledge that God's love for us is profound, and that there are things that we can do that make life harder for ourselves, and that needs to be addressed. And we're all of that. And so we're not trying to espouse at all, well, we're just looking only at scientific psychological principles. We are saying we believe that all truth is God's truth. And if science has something to teach me about my body and my brain, I'd like to know it. And I also know that God has things to say about my soul and who I am and my person, and I want to know that as well. So what we are saying is that both matter, both are important, and it all fits together in us as whole beings. Anything you would add to that?
I thought it was
I just say on top of what you said, Kay, is we know here at Saddleback that when it comes to being impacted and hurt by mental illness, the church is a great place here to become and belong and receive support. Right now, we're dealing with incredible stigma. And we have advocates like Steve and those here on the stage and many of you out there that somehow in some way our culture, our society, or even maybe telling ourselves that if you're living with mental illness, you're somehow subordinate or somehow, not part of the group. You get marginalized, pushed away. But what we're saying here at the church is, no, you're one of us. You belong in community. You were created for community. We love you, and we will journey with you wherever you're at and whatever stage you're in, living or having been impacted by mental illness.
Yeah. This is not an us and them.
Yeah.
This is an us. And us. One other thing, and then we're going to ask our exhibitors, some of them, to come up and just tell you really briefly what they do, what the organization does. And as they're coming, there's one other question that came up about law enforcement and raise the issue that often happens in some very high-profile professions where people might be living with a mental illness or struggle with suicidal thoughts, but are very fearful of disclosing because of the effects that could have on their job, whether they might be fired, whether they might be marginalized, whether they might be not given an advancement because of the fear or anxiety within an employment situation. And if you specifically ask that question, I'm so irritated, my mind is blanking. There is an organization that I want to share with you in law enforcement on of police officers that have banded together around the country to support each other and fellow officers living with mental illness. And we'll put that online for those of you if you want to check back in. But there is a specific organization, and I want to tell you about it. So our exhibitors, are they here? Are they behind me? It's like, surprise, they're popping out here. Come on out. It's like, come on down. Thank you so much. Yeah, and share the mic. So just take a minute or two and tell us a little bit, just briefly, about the organization you're representing today.
Hi, my name's Susan. I work for NAMI, the National Alliance on Mental Illness. We provide education, support groups, presentations for people with mental illness and their family members.
That's good. And there's a table.
Oh yeah, the table's back there.
Thank you. Hi, my name is Asita. I'm a licensed marriage and family therapist working for the Orange County Healthcare Agency Behavioral Health System. I'm introducing OC Links to you today because the healthcare agency is a very large system with 200 different programs. Some treat mental disorders, some substance use disorders, some are dual diagnosis, inpatient, outpatient. So you can imagine it can get very complicated for the consumer to find an appropriate program. And that's where we step in. We help you if you call us, we find appropriate program, and we can even warm link you to the program. It's for all ages and all severity levels. So please visit our tables. Thank you.
Thank you.
Hi, everyone. My name is Inez Noto, and I'm Manager of Community Physician Trainings at Children's Hospital of Orange County, also known as CHOC. And Dr. Mandani, Pastor Mandani, I'm sorry, did a great job of kind of walking us through all the levels of care. And I have to give a shout out to Rick and Kay Warren for their support. We just celebrated a year of our mental health inpatient center having opened. So thank you so much for all of your support. And that is the first inpatient center in Orange County to see children or accept children under the age of 12 years old. So that's a really big deal for us here in Orange County. So under 18, and our youngest was 3 years old. So definitely that's wonderful. We also have mental health emergency services as part of CHOC. We also have an intensive outpatient program as well for adolescent teenagers in high school. And we have outpatient services, and we also have our co-occurring clinic. It also sees children with a medical diagnosis along with mental health issues, but that one is just for CHOC. And then there's a program that I oversee, which is part of what we do here. We do community outreach, mental health trainings for primary care physicians. We do mental health trainings for schools, and then also for communities. So come see us, and we'd be happy to kind of explore more and talk to you a little bit more about what we do at CHOC.
Thank you so much. Thank you. Okay, let's stand. I'm going to dismiss you. And we haven't prayed today. This is a workshop. It's not a worship service, but we're in God's house. And so it's a moment just to, as we were talking about, caring for your whole person. So let me just pray for us as we leave today. Father, I thank you for the men and women and the students that have been here both in person and online. We're bringing to you our deepest pain and heartache and sorrow, both for ourselves and for our loved ones. And grateful that you are a God who cares. We've talked about compassion, and you are the Father of compassion. And if we didn't know that your love for us was unchanging and had nothing to do with our life circumstances or our level of wellness or illness, we would be in despair. But you tell us over and over again how beloved we are, and we rest in that place of being your beloved today. I ask that as we go from here, that this would be an encouragement and a thing to look back on, to know that we're not alone, that we were with people today who care about the same things we care about and care about each other. So we go and ask for your blessing in the name of your Son, Jesus. Amen.
Amen.
Thanks for being here.